And now we are switching to our final clinical case. And again, we would like to ask Dmitry to introduce the next patient. That's our last patient. That's a woman, 18 years of age. Primary or preliminary diagnosis, autoimmune cholangitis with cholestatic syndrome, and CBD middle throat stricture. Patient history. She thinks she feels sick since March this year, feels pain in the right upper quadrant, loss of appetite and loss of body weight. Since July this year, she developed signs of cholestasis, of cholestatic syndrome. The most important, we should take into account elevation in titers of autoimmune markers. She developed anti-nuclear factor, smooth muscle antibodies, and anti-cytoplasm antibodies. AUS of pancreatic biliary system in October this year, it showed local stenosis or CBD stenosis in its intrapancreatic part with suprastenotic dilation up to 12 millimeters and with thickening the CBD wall up to 3 to 5 millimeters. The MRI 1 month later showed fibrotic liver alterations, dilations in intra and extrahepatic bile ducts, and the local stenosis intrapancreatic segment also was of CBD was confirmed. In her labs we see elevation of leukocytes and neutrophils. We see elevated ESR and inconsiderable increase of platelets. Blood chemistry showed signs of cholestasis with normal bilirubin and transaminases. So, generally speaking, the patient has the following diagnosis: autoimmune cholangitis and the CBD middle throat stricture. We plan manipulation in ERCP with biopsy of bile ducts, and we plan bile stenting to restore patency of her biliary system. And that's it, I suppose. Any questions? Yes, Corinne should ask a question. Not into the mic. Not into the mic. So you said cholangitis. No, it's not cholangitis. Cholangiopathy, autoimmune cholangiopathy is such a name for primary biliary cirrhosis. I'm like a I would like commenting for therapists in the room. So you consider, you think it's a PSC here, or you see it's a stricture of unknown origin. We consider stricture of unknown origin, but on the basis of your morning lecture, I wanted to think about to be more specific about the etiology of this stricture on the basis of endoscopy data and presence of serologic markers of autoimmune inflammation. I think we can preliminarily think about it. So we think about primary sclerosing cholangitis. No, not on the PSC, but mostly about the new form, or this form which you talked about, this IgG4. And we think about the type 4 with distal involvement, with distal lesions. If it's not yet to include, that's just for women, because it's a patient, it's a woman. So mostly the first type is a man of middle age, yes. But it's not always, yes, it's not always. It could be a woman with such pathology. No more questions? It's on opisthrochosis. No, there were no, we didn't study for that. So we had several patients with opisthrochosis. It's a very valuable addition. So, esteemed colleagues, any more questions? No? No more questions? Yeah, thank you. Thank you, Dmitry. Could we switch to the operating theater? Eugene, you're here. We also can see you. We have on screen we can see us on the screen. So Dmitry told about the patient. Just not to waste time, we cannulated her CBD, and if our technical specialists, if they show endoscopy and X-rays, so I mean Olympus, and you see that the catheter in papilla. There is a small parapapillary diverticle with some diameter.
Diverticulum.
Okay, so it's a bit hard to see here because the catheter compresses it, but there you get the idea that the papilla is very small and it's a little bit sunken in this diverticulum here. We don't know what will happen in the future because the patient is very young, but this could turn into a large diverticulum later, at some point.
Yes, I just fix the notice on this point because somehow doctors think that parapapillary diverticulum is contraindication for RCP. But I think it could be difficult sometimes, but it's not a contraindication.
No. Diverticular can be the reason for cholestasis, and then you have to do something. And to have an operation on everyone who's got cholestasis due to his diverticulum would be a little bit much, in my opinion.
Yes. And what we can say about the X-ray picture?
Okay, so we've injected, but you don't see much now. I'm going back into the right hepatic ducts, and you see here another example of chronic inflammatory biliary disease. So this is a cholangiogram which is very much consistent with primary sclerosing cholangitis again, because you see this typical bead-like appearance of the segmental ducts, and what you don't see are the peripheral ducts, the very tiny ducts. They are already gone. So this in itself is a diagnostic picture of a primary sclerosing cholangitis. And we can see that the right liver lobe is rather small, even without looking at the MRI pictures. And when you look to the left-hand side, the left hepatic duct is long and the left hepatic lobe seems to be enlarged. We try to cannulate the left hepatic duct now, please. Okay. Try to get the wire there. Fine. Sorry. Fine. Okay. Pull.
Okay.
No. Okay. No. Sorry. You have to push the wire in again, please. Okay. Like this, maybe. Yeah.
Okay.
This was better.
It's just jump.
Yeah.
Okay. It's
just
better.
Pull. There we are. Good. So let's try to move over here and inject more, please. Here, you see enlarged ducts here, enlarged duct. There is no real stricture here. Yeah, you just see very large ducts on the left-hand side here without any strictures, and this is another appearance which is not typical for PSC, but it can happen that you've got ductal dilation of the main ducts without strictures. It's a little bit like bilioma, really. Yeah, so no stricture here for to cause this. So, but this is just to get the idea that this is very probable a primary sclerosing cholangitis, although we've got no information about a simultaneous chronic inflammatory bowel disease, but it can be that this is only diagnosed later or she doesn't have it at all. The thing we were looking at before was the common bile duct, and you see a opacified common bile duct here, which got a diameter of, let's say, 10 millimeters. Compare this to the diameter of the duodenoscope, which is 13 millimeters. And then you see that contrast filling is ending here. Yeah, there's a stricture, obviously there's a stricture. And now we do a filling of the peripheral duct, please. Inject some more contrast. Yeah, and you see that the peripheral duct is very narrow here, very narrow, and here's the problem. Here's the stricture. Okay, and of course this can happen in PSC patients without any malignancy, but this is a stricture which is causing cholestasis. You see that the proximal and middle part of the common bile duct is enlarged, so this is something you have to assess for tissue, for dysplasia, for malignancy, even in a young patient. So let's exchange the catheter for a sphincterotome, because I'd like to try to take a histology sample.
Okay.
And I will never get the biopsy forceps in without a sphincterotomy here.
What do you think about necessary to perform sphincterotomy in this case?
Yeah, the thing is the following. Yeah, of course I try to avoid sphincterotomy in any case where it's possible, because sphincterotomy in itself is a procedure with a certain risk to it, mainly post-ESCP pancreatitis. But on the other hand, this lady, she will presumably have a number of ESCPs throughout her life. She's got strictures just now, so just to diminish the risk of subsequent procedures, endoscopic sphincterotomy is an option here. You can always debate about the risk of infection and all that, but she's a young woman, and imagining her having a primary cannulations twice a year without a sphincterotomy does not sound good to me.
And could you tell a couple words about our plans? What we plan to do?
So,
that we discussed about.
We've got two things. The first task is diagnostic. Try to get a biopsy or at least a brush cytology of this distal stricture, and then as we see that the bile is not flowing out freely, we've got an indication for therapeutic measures. And therapeutic means, in this case, the first thing I do in strictures in PSC is balloon dilation.
Yes.
And we will perform that. And if we see that this stricture is not opening up at all during balloon dilation, we can opt for stent implantation, at least for a short period of time, as we were discussing just in the other case. Okay. So the sphincterotome is here.
Yeah.
Gently, gently, gently. So I insert it to the end of the cutting wire, and then please put a little bit of tension on it, and I try not to cut too much. Yeah, more tension, please. Okay. Yeah, a little bit more.
Okay.
Okay, that's it. That's for the moment. Exchange, please. And I try to get in a forceps now.
Okay.
If this is not enough, maybe we have to do a bit more of a sphincterotomy.
And what is the target of our biopsy?
The target of the biopsy would be the region just below the enlarged duct. So one could ask for intraductal ultrasound, but we don't have this at hand right now. So what we do is we try to get a proper piece of tissue here.
And what do you think about biopsy of papilla vaterae in this case, in these patients?
The biopsy of the papilla?
Yes, papilla.
Yeah, I mean there is a role for biopsy of papilla in suspected autoimmune disease,
Yes.
autoimmune pancreatitis, autoimmune cholangitis. But then usually in those cases the papilla is swollen. You've got a swollen and very tender papilla which will start to bleed the moment you touch it or you even look at it. This is a very, very tiny papilla, which is more typical to PSC. So I don't think that taking a biopsy of the papilla would bring us far. Again, very gently, I try to insert the forceps here. You see that the bile is already flowing out.
Yeah.
So take this away, please.
Можно убрать.
Good. So this is, you see that the forceps is at the point of the stricture. So please
Yes.
open the forceps.
Okay.
Which may be difficult in a stricture, but I think you got it. Bit more. Yeah, it's opening. You see that?
Yeah.
Okay, so now please close it, close. Good. So, and take it out. And let's see if something's inside.
Okay, we just they still empty.
Still empty. So let's try it again. Yeah, this can happen. Because, of course, inside a stricture, it's hard for the forceps to open.
Of course, and we have only X-ray picture, and this is 2D pic, not 3D picture.
Sure.
But right now, the moving with biopsy forces is more easily than in patient before.
Yeah.
Before,
So, what else we can do is open. So now I open it in the enlarged part and I withdraw. This is a bit tougher.
Yeah.
So, and now I'm moving it forward. And now please close it. And now you should have something. Okay?
Okay, we will see.
If not, you can send me home.
No, Alex, you will stay here.
Okay, good. So let's try this once or twice again, please.
Of course.
Because pathologists, in my experience, are the happier the more tissue they get.
Yes, the best way for pathologists to be happy is to take whole CBD,
Yeah.
whole liver, and
So
just see it.
that's not on offer today, but
Yeah.
let's see.
Because we try to do it mini-invasive.
Yeah. So-
How usually how many spaces do you try to get in these cases?
4 to 5 is the usual. Of course, you could say as many as possible. At some point, you have to stop. So, okay. Look at this. Okay, this is
Yeah.
really hard tissue here. Okay, close, and zack. Okay.
Okay.
Good. This is a pretty easily accessible stricture, even if it's hard to open the forceps. It's easy to access it. So I see this as the better alternative to cytobrushing here. If someone's got a different opinion, please tell me. It's not a problem.
Oh, but I think brush is more easy, of course, for producing, but it's less informative.
Yeah.
Yeah, in these cases. And this is the one point. And another one that we have a very good X-ray picture, and we can very easy move and get new place in CBD.
Yeah. So, okay, open.
Open.
And it's a tight stricture, and it's really hard,
yeah,
hard
we
tissue.
see.
And close. Okay. So maybe one more, and then we're done with that.
Okay. I have. Покажи мне кусочки.
So you
Show me those pieces.
in passing the forceps a few times through the stricture, the contrast has started to flow out. So I think dilation could be beneficial here, and maybe we don't need to stent her, which is not the most favorable option. So
Yes, okay, let's see.
let's see.
We'll try to do it.
Good. Open,
Yes.
and here's the stricture. Withdraw. Yeah. Oops. That's a good position. And close, please.
Very slow to close.
Good. Okay.
It's like stone.
It's a bit like that. Yeah. Good. So we've got a few specimens in the jar.
Yes, absolutely. We are sure that we have three specimens there.
Good.
inside.
So then let's
balloon. The
yeah.
D2
Right.
So now we will use a balloon. What solution do you use for make a pressure?
In the
Is
balloon?
it- In the balloon,
Yeah.
yes. It's just saline or saline with contrast or air. And
Yeah.
is it important to do this way?
Okay, I think air is not a good option because air is very much compressible. So meaning fluids which are much less compressible are better for this procedure. You should always use a fluid, and of course it doesn't matter really which fluid you use, but if you use a mixture of saline and contrast, you get both things. First, the saline keeps it very fluid, so it's not too hard to pump through the channels, and the contrast will give you an idea of how the balloon is inflating, and this is something we need here. Do you have some contrast in that? Good.
Yes.
So because we have to see if the balloon is inflating completely or not, and for that you need some contrast. So.
Okay, but one not very good option in Russia for contrast is that it's like glue. That's
it. Yeah. That's not
we
just in
can
Russia.
use this balloon second time.
This is not just in Russia. Yeah.
Really?
So pull a bit, please, on the wire.
Okay.
So here's the balloon. So advance. The balloon has got 2 markers. So now I'm pretty sure that it's crossing the stricture. So maybe you try to inflate now.
Okay. What pressure do we need?
You just start. Ah, yeah, okay. Deflate. I'm too fine. But this way, with a little bit of contrast, you see exactly what's happening here. I have to go down. Please inflate again.
Okay.
There you see. Now you see the stricture,
excellent.
right? Okay.
Yes. And it's work.
Yeah, it works. Yeah. So the stricture now it's gone, basically. Yeah. So this is exactly the effect we want to have, and which is usually the effect in PSC patients. And now we leave this balloon inside. There's no international standard on how long, but in the place where I work, we've got the standard of dilating non-malignant strictures, and I'd like to think that this is non-malignant for at least 2 minutes.
2 minutes.
Yeah?
Okay, so you have to tell a funny story for us, because during 2 minutes we will just stand and
So this is, I mean, balloon dilation is the most common intervention beside biopsy or cytology taking we have in PSC patients, and whenever it's possible to cross the stricture and to dilate the stricture, you have the opportunity to get a feeling about malignancy or not malignancy, because a stricture which is very hard to dilate and which will not react anyhow, which will be there 2 days later again, this is a stricture which lets you feel that's not a good idea, not a good thing, because this might be malignant. But when a stricture is reacting over time, then you get a good feeling that this is not malignant. You get the feeling that the peripheral ducts are working better because drainage is better, and then you can, at some point when you see that the stricture is not functional anymore, you can stop treatment. Yeah. In a case like this, I would ask the patient to come back for repeat ESCP in 6 months. Maybe if she's got problems before, of course she can always come, but I would repeat balloon dilation of strictures at least twice a year until the strictures are gone.
Okay.
Yeah. And this is the concept I showed in my presentation when you combine endoscopic therapy of strictures and UDCA therapy, then the survival probability will be better.
Yeah.
Okay.
Yeah, it's true.
So 30 seconds more time for funny stories. Now it's your turn.
I'm very serious doctor, so I don't know any funny stories.
Okay, good.
Yes, but the balloon absolutely straight, so we don't see any bands there.
Right.
It seems that the balloon is walk, and we don't need the stenting in this case.
Let's just, we take out the balloon, and then we go in with the catheter again and do another cholangiogram.
Okay.
And then we see the before and after picture, and this gives us a good idea of what happened in there, really. Yeah.
Okay, yes, I absolutely agree. And did you see that this patient have a high level of have leukocytosis? What do you think about this? Is it this liver disease is the reason for this leukocytosis, or just?
It is, at least it is a risk factor, because people with a primary sclerosing cholangitis have a high incidence of bacterial cholangitis, really. And you don't have to introduce the bacteria through the papilla. Sometimes it's just bacteria which were in the bloodstream from something else, a general infection or something, and they invade the bile ducts. And then, because the bile ducts have no auto clearance as they do in healthy people, a bacteria can stay there and develop into full-blown cholangitis. So deflate, please.
Okay.
Time for funny stories is over. Okay, so you see how the contrast is sucked from the balloon? Okay, and now I can easily remove the balloon. Of course, the wire has to be pushed at the same time, which Evgeny just now does. So you see there's hardly any bleeding, which is a good sign again, because I mean the main differential diagnosis is malignancy or scar tissue. And you know that cholangiocarcinoma often bleeds very severely after dilation. It always stops. I don't worry about that, but this is a bad sign, really. And here we've got hardly any bleeding.
Yes, but due to ultrasound examination, I mean endoscopic ultrasound, we had very good visualization of CBD, and we didn't see any tumor suspicion places. So I think the tumor is, less
probable.
Less probable.
Okay, yeah, I understand. Sure, but the thing is, in PSC patients, you're always dealing with probabilities, and this doesn't help the single patient who's sitting in front of you. I've had very frustrating experiences with that.
Евгений Геннадьевич, у нас вопрос можно задать?
We have a question. Can we ask you a question? Sergey has a question. Could you tell me, please, we made 3 or 4 biopsies, so what you've got, could you show it us or maybe comment on that? Well, I don't know if you can see it. We have inside 2 pieces, like in case of usual. Could you see? Could you see that? Could you see this? My chest. I don't know if you can see those pieces. There is 2 pieces of the size of usual biopsy, which we usually do from the GI tract, and there are several small pieces. So I think there is lots of work. Could you place it to a darker background, against darker background? We need something. I need something black. Could you move it up? Our anesthesiologist will come. He just came from the vacation, so he's lots of his sun tent. I don't know if you can see those pieces. They're really whitish. It's about 2 millimeters, 2 millimeter size of those pieces. Yeah, about that. Okay, good. Could you tell Alex it's good biopsies? It's not, of course, the whole liver, as morphologists would like to say, to have in Germany, but for us it's quite enough.
Now let's inject, please.
Sorry, I'm just a moment.
So you're wetting our
Можно
feet.
пока еще один вопрос?
Ask you one more question.
Мы законтрастируем холедах.
Okay, so you see how the stricture has in part resolved, okay? It's not as tight as it was before, and you see now a continuous flow of contrast going down. So in this case, I would not put in a stent because I see that it's flowing out now. The picture may be different when she returns and the problem is the same again. Yeah? But as I told you, stenting in PSC is always a matter of debate, and I'm not one to advocate very regular stent placement. I would leave it like that. Yeah.
Okay.
Look how the air is going up.
Yes.
Yeah. So
Yes,
this
we
is a
see
good
it.
sign of continuity.
Okay. And Иван Владимирович, ваш вопрос?
What's your question? Well, I got the part of the answer. The question was when we should place the stent, when it is more preferable to place a stent, or where we shouldn't do that. I'd like to remind you that there was a discussion regarding stenting, and it was said the bacterial infection, bacterial cholangitis in PSC patients is rather frequent situation. And stenting is limited with this complication. If we can avoid stenting, it's better to avoid it. If we have to do that, and the stricture cannot be just dilated, then we do stenting, but we place stent not for 6 months, like in case of the benign strictures, but stenting is made just for several weeks, not for 6 months.
I would say so. Yeah.
Okay.
Good. So we withdraw.
Yes, we absolutely do everything that we planned.
So you see that it was not a very large sphincterotomy, but it was enough. Yeah, you
Yes.
see the air going in and out, and this is no problem for her. I hope so.
And
yeah?
what do you think about post-RCP pancreatitis in this case? Because she's very young,
Yeah.
and we saw the
Pancreatic duct,
there,
yeah.
yes,
So-
and we perform papillary sphincterotomy.
My first option would be to use a anti-inflammatory suppository now. Yeah, either indomethacin or diclofenac.
Okay.
Yeah.
Okay, maybe what do you use usually? Maybe some more. What do you think about somatostatin in this case?
To be honest, I've got no experience with somatostatin.
So you don't use it in your place?
Not for prevention of post-ERCP pancreatitis. What we use regularly and what I would use in this girl is a suppository of 100 milligrams of indomethacin or 75 milligrams of diclofenac.
Okay.
Yeah?
Thank you very much. Okay, we can go out and maybe some questions from audience. Виктор Анатольевич, мы готовы ответить еще.
So we are ready to answer some questions if you have any. If there is no more questions, our patient is going to wake up, and we'll come to the audience and continue the discussion. Thanks a lot. Thanks, Dr. Deshan. We're waiting for you. Thank you. So we're going to be here. We're going to be with you soon. Thank you. So let's thank our colleagues. Let's applaud to them.